Imagine you are a highly skilled surgeon.
Yeah.
A patient walks into your clinic asking for a totally standard routine cosmetic procedure.
Right, something you've done 100 times.
Exactly. You book it, you perform the surgery flawlessly, and the physical healing process goes perfectly.
What the?
But because of that technical success, your patient's psychological state completely collapses.
Yeah, it is. It's the ultimate clinical paradox. You did everything right with the scalpel, but the outcome is just an absolute disaster for the human being sitting in front of you.
Which is wild to think about.
Hmm.
Welcome to the Deep Dive, everyone. I'm your host, and with me, as always, is our resident medical expert. And today, we are wading into the multi-million-dollar industry of female genital plastic and cosmetic surgery.
We're talking about procedures like labiaplasty, vaginoplasty, and, various regenerative laser therapies.
Right. And for many people, these interventions alleviate genuine physical discomfort, or, they just provide a welcome aesthetic change. But this field also exists in this really murky, highly complex diagnostic space.
Mm-hmm.
The line between a simple physical adjustment and a deep psychological vulnerability gets blurred incredibly fast.
And that blur is dangerous. A practitioner isn't just looking at tissue, right? They are navigating a complete ethical minefield.
Yeah.
They have to figure out if the patient actually needs surgery or if they are, trying to use a physical procedure to basically mask a profound psychosexual or relationship crisis.
Which is the core mission of our deep dive today. We've got a really fascinating stack of sources to help us spot these psychological tripwires.
It's a great stack today.
Yeah, we're pulling heavily from medical textbooks on female genital plastic surgery, specifically the clinical insights of Dr. Michael Goodman.
Right.
And we're looking at that alongside patient psychological safety guidelines from the JCCP, plus some very clever clinical screening tools.
And the central question this entire stack of research tries to answer is, well, it's simple to ask, but incredibly hard to execute.
How do you know when to operate and when to stop?
Exactly. And to figure that out, we have to establish the biological and psychological reality of what these procedures can actually achieve. We have to separate the physical reality from the psychological fantasy.
Okay, let's unpack this. Reading through Dr. Goodman's clinical texts, the distinction between medically necessary reconstructive surgery and, elective cosmetic procedures seems completely fundamental here.
No, it's the foundation of the whole dilemma.
Right, because reconstructive surgery is fixing a clear mechanical problem, like repairing a severe tissue tear from childbirth or addressing pelvic organ prolapse. The goal is just restoring baseline function.
Whereas the cosmetic and regenerative side is completely elective, the goals are highly subjective. A patient might want an aesthetic change just to feel more confident in a swimsuit. Or they might seek subjective functional enhancement, like, increasing friction during intimacy.
Which is fine, but the problem arises when the expectations for that elective procedure transcend the physical body, right? When it crosses into this idea of emotional salvation.
Yes. Because female sexuality is an incredibly complex neurobiological web. The sources hammer this point home repeatedly.
Yeah, it's not just a plumbing issue.
Exactly. It's not. A woman's sexual response relies heavily on psychosocial factors, relational dynamics, stress levels, emotional safety, all of that.
That is the exact friction point for clinicians then.
It really is. You cannot operate on a marriage. You cannot laser away past trauma.
Wow. Yeah.
A major diagnostic stop sign is when a patient explicitly places the burden of their relationship's survival on, say, the outcome of a vaginoplasty.
Think about the last time you, the listener, bought a new outfit or got a haircut to make yourself feel better after a horrible week.
Right, we've all done that.
It's a temporary boost. Yeah. But taking that mindset and scaling it up to permanent surgical intervention, it's like thinking buying a new dress will cure clinical depression.
That's a great way to put it.
You're treating the packaging, but expecting the contents to magically change. At what point does an expectation cross the line from optimistic to, clinically delusional?
Well, the clinical texts take that a step further, specifically regarding deep-seated psychological trauma. The literature notes that patients with a history of sexual abuse might associate their genitalia with feelings of disgust or contamination.
Oh, wow. And so they view the surgery as a way to physically, cleanse themselves of that history.
Right. They are seeking a physical excision of a psychological ghost.
That's so heavy.
It is. And if a surgeon complies, And the physical tissue changes, but the trauma remains completely untouched, while the patient's distress can absolutely skyrocket.
So in those instances, the ethical mandate isn't a scalpel at all.
No, it's an immediate referral to a psychosexual counselor who can actually address the root cause.
I found another fascinating expectation trap in the sources, actually. The myth of the miraculous physiological rewiring.
Oh, yes. This one comes up a lot.
There are accounts of patients requesting a procedure with the strict expectation that it will suddenly allow them to experience vaginal orgasms, when historically, their body has only ever responded to clitoral stimulation.
And that is a fundamental misunderstanding of human anatomy that the surgeon just has to correct.
Right.
I mean, a procedure might tighten tissue or alter frictional forces, sure, but it cannot fundamentally rewire a patient's neurological pathways or physiological sexual response.
So if a surgeon explains that her current experience is a completely normal variation of human biology,
And the patient still demands the surgery to change her neurology, the procedure must be denied. The expectations are clinically delusional at that point.
so we've been looking at the pressure inside the patient's own head. But what happens when that pressure isn't internal?
Ah, right.
What happens when the person driving the surgery is actually the person sitting next to the patient in the consultation room?
The third person in the room. This introduces the incredibly thorny issue of coercion and partner dynamics.
Yeah, this part of the reading was intense.
It's crucial, though. True autonomy is the bedrock of medical ethics. For informed consent to be valid, a patient has to request an irreversible procedure of her own volition, entirely free from external force.
Yet, the data you provided threw me for a loop. Roughly 5% of women undergoing these procedures report doing so, specifically at the urging of a sexual partner.
Yeah, 5%.
5%. For something this intimate and invasive, that feels alarmingly high. I mean, if you're a clinician with a standard 20-minute consult window, how do you practically separate a partner who is just being supportive from a partner who's being coercive?
It's really tough. It requires a level of hypervigilance that almost borders on forensic psychology.
Wow.
The clinical texts outline the behavioral cues of a healthy dynamic versus a toxic one. A healthy supportive partner might say something to the surgeon like, this isn't my idea, I love her as she is, but I'm here because this is something she really wants for herself.
So the patient is clearly the one driving the bus, and the partner is just along for the ride.
Exactly. But the clinical warning lights should flash blindingly bright if the romantic partner is the one actively advocating for the surgery.
What does that look like in practice?
Well, Dr. Goodman details specific behavioral cues to watch for. For instance, who is doing the talking? If the surgeon asks the patient a direct question about her symptoms and the partner answers for her, that is a profound power imbalance.
Or the vocabulary the patient uses, right? The text mentions listening for deferential language.
Yes, exactly.
Like a patient saying, whatever he thinks looks best, or he says it feels too loose lately. The minute a surgeon hears that a procedure is being driven by a third party's likes, dislikes, or worse, their derogatory comments, the ethical foundation of the surgery just crumbles.
Because you are no longer treating a patient's physical complaint. You are treating a symptom of a toxic relationship with a surgical intervention.
That is wild to think about.
It really is. The modern aesthetic clinic has to be an environment where power dynamics are assessed just as rigorously as tissue laxity.
I mean, a cosmetic surgeon having to play the role of an impromptu relationship counselor. It's crazy. But if they don't, they risk basically facilitating abuse.
That's the reality of it.
But let's pivot, because as complex as that external partner pressure is, the sources indicate that the most dangerous pressure a patient faces is often a severe internal distortion.
Right.
Specifically, body dysmorphic disorder, or BDD.
What's fascinating here is that BDD is a complex, severe psychiatric condition. It goes far beyond standard, everyday insecurity.
Right, we all have insecurities, but this is different.
Completely different. It is characterized by an obsessive, all-consuming preoccupation with an imagined defect in one's appearance. Or, if there happens to be a slight natural physical anomaly, the person's distress is markedly excessive and debilitating.
The JCCP guidance paper points out that while BDD affects maybe 0.5% to 0.7% of general population, the prevalence skyrockets when you look at aesthetic consumers.
Which makes logical sense, right?
Totally. If you are obsessively distressed about your appearance, you are naturally going to gravitate toward the very industry built on altering appearance.
But the danger for the clinician is that a patient with BDD often presents incredibly well at first.
Really? How so?
Well, They are highly researched, they know the medical terminology, and they are extremely motivated.
But the sources highlight a tragic irony about that motivation.
Yeah.
You would assume that someone who is obsessively terrified about their body looking wrong would be petrified of a surgery failing, right?
You would think so.
But patients with BTD are actually significantly less risk-averse than the average person.
Yes. They will gladly accept disproportionate procedural risks. We're talking severe scarring, permanent nerve damage, chronic pain, just to fix what the rest of the world sees as a microscopic or non-existent flaw.
It reminds me of someone who is so pathologically terrified of a tiny spider on the wall that they are willing to burn their entire house down just to get rid of it.
That's a great analogy.
The risk of the fire doesn't even register in their brain, only the spider does. The BDD patient is so focused on the perceived flaw that the reality of surgical complications just becomes invisible to them.
That is a perfect way to visualize the cognitive distortion at play here. And because their risk assessment is broken, clinicians have to actively hunt for BDD indicators.
Like what? What are they looking for?
One of the most glaring is the cosmetic shopper.
Oh, right.
This is a patient whose medical history reveals a long trail of seeking interventions from multiple different practices across various specialties, usually with a pattern of diminishing satisfaction.
The JCCP paper also lists time-consuming behavioral compulsions. We're talking about hours spent excessive mirror gazing, constantly comparing their specific features to others, extreme camouflaging tactics, ritualistic skin picking.
And a relentless need for reassurance that never actually suits them.
Exactly.
Dr. Goodman makes another crucial distinction regarding the nature of the patient's complaint. A healthy, ethical candidate for these specific procedures usually presents with an isolated complaint.
Right.
They are bothered by a specific functional issue, like chafing during exercise or the appearance of one specific area.
Contrast that with the BDV presentation, where a patient walks in with a litany of body image dissatisfactions across their entire body.
Yes. The genital concern isn't an isolated issue. It's just one item on a long, rolling grocery list of perceived deformities.
So if a clinician sees a patient who has previously undergone a half-dozen variety of body alterations, and now they're requesting a highly specific, narrow genital result to finally make them perfect,
the surgeon needs to halt the process immediately. And BDD isn't the only psychological condition that requires this either.
right? The texts list a whole spectrum of mental health contraindications that demand an immediate pause. Active depression, severe social phobia, substance abuse, active intoxication during a consult.
Which happens more than you'd think.
I bet. Also, obsessive-compulsive disorder and eating disorders. The logic here is that true informed consent requires a person to have the unclouded capacity to make medical decisions.
If a psychological disorder distorts a person's view of reality or themselves so severely that they cannot rationally weigh risks and benefits, they lack the capacity to truly consent.
So the ethical move is to refuse the cosmetic surgery and refer them to a mental health professional. Okay, so those are the big, glaring psychiatric diagnoses. But I want to drill down into the subtle stuff the sources covered.
The soft findings.
Yeah, the behavioral cues in the exam room that don't necessarily scream psychiatric crisis, but still predict a terrible outcome. It makes me think of the check engine light on a car dashboard.
I like that.
The car is still driving fine, the engine sounds okay, but those subtle electronic blinks are telling the mechanic that a catastrophic breakdown is imminent if they don't pull over.
Seasoned surgeons develop a highly calibrated radar for these behavioral check engine lights. Like you said, Dr. Goodman refers to them as soft findings. They are subtle indicators that predict a profoundly dissatisfied patient, even if you execute the surgery flawlessly.
So break some of these down for us. What are these soft findings actually telling the surgeon about the patient's internal state?
A major one is the patient's level of engagement. If there is a noticeable lack of eye contact or a highly passive, almost detached approach to the consultation.
Like they're just checking a box.
Yeah. If they aren't asking questions about the recovery process or the potential complications, they aren't engaging with the reality of what they're about to put their body through.
It's a form of dissociation from the physical trauma of surgery. What about how they interact with the clinic itself?
Compliance and respect are massive predictors of surgical success. If a patient is consistently late to their preoperative appointments, if they fail to pick up necessary prescriptions beforehand, or if they brazenly disregard basic preoperative instructions.
And the classic rude to the receptionist test. Right?
Oh, always.
If they treat the administrative staff poorly, but turn on the charm for the doctor.
That behavior is a massive warning indicator. If a patient is non-compliant or dismissive when the stakes are low before the surgery, they are virtually guaranteed to be non-compliant with the rigorous post-operative care required.
It makes total sense.
In genital surgery, you are dealing with an area of the body prone to constant friction, moisture, and tension. If a patient ignores resting protocols or hygiene instructions, you are looking at a high risk of wound dehiscence.
Wait, wound dehiscence?
Yeah, which is the medical term for the surgical incision literally bursting open.
Oh my God.
Along with severe infection.
So a bad attitude in the waiting room directly correlates to a physical wound rupturing 3 weeks later. That is a wild connection.
It is, but it's incredibly accurate.
What about during the physical exam itself?
The clinical texts note that excessive compulsive touching of the area during the physical examination can indicate an obsessive fixation.
Right.
It links right back to those underlying BDD concerns. You also have to gauge their reaction to professional boundaries.
Meaning what exactly?
If a patient is too busy to listen, or if they display a hostile adverse reaction when the surgeon suggests a slight revision to their grand plan to ensure safety, that inflexibility is a major warning.
I want to bring up the photograph issue because this one really stuck with me from the read.
Oh, this is a big one.
The text warns against patients who bring in a photograph,
Yeah.
maybe a heavily edited image from social media or adult content, and demand to look exactly like that. My first instinct as a layperson is, well, isn't that just normal Pinterest culture?
Right, everyone does it.
People bring photos to their hairdresser all the time to show what they want. Why is it a diagnostic stop sign for a surgeon?
Because a surgeon is working with a patient's unique living anatomy, not sculpting blank clay. A photograph from a magazine represents a completely different human body, often altered by lighting, angles, and digital editing.
Right.
When a patient demands an exact replica of a 2D image, it shows a profound inability to accept the surgeon's realistic preoperative aesthetic goals.
They are basically demanding...
A physical impossibility, right, exactly.
And sources talked about symmetry too, right?
Yes, take the concept of symmetry. Natural asymmetry is a biological baseline in paired organs, including the labia. One side is almost always slightly different from the other.
Which is perfectly normal.
Completely normal. But if a patient cannot intellectually grasp that natural variation and demands mathematically perfect symmetry, they are not a viable candidate. If a surgeon promises that perfection or bends to a patient's demand for it, they are architecting their own failure.
We have mapped out an absolute minefield here. Coercive partners, hijacking of the consult, the inverted risk aversion of body dysmorphic disorder, impossible physiological expectations, and the subtle behavioral check engine lights.
It's a lot to navigate.
It really is. So how does a modern practitioner actually safeguard these vulnerable patients? They can't just rely on a gut feeling or try to play amateur psychologist in a 20-minute window, can they?
No, relying on gut instinct is a recipe for malpractice. Because these surgeries are purely elective, the foundational medical ethics of non-maleficence, meaning do no harm, and beneficence, meaning act in the patient's best interest, must dictate the workflow.
Then they need a system.
Exactly. Practitioners have to rely on validated, objective tools to filter out the psychological noise.
Let's talk about those screening solutions. Instead of just listing off the acronyms, how do these tools actually work in practice? Take the Cosmetic Readiness Questionnaire, the CRQ.
The CRQ is brilliant because it doesn't just ask, are you crazy? It uses validated psychological scales to subtly assess underlying distress, self-criticism, and pathological perfectionism.
Smart.
It categorizes patients into green, yellow, or red zones based on their answers.
So green means the patient has realistic expectations and is likely to be satisfied, I assume.
Yes.
And yellow means slow the process down, have a much deeper discussion about their motivations.
And a red zone score acts as an objective hard stop. It indicates a statistically high risk of postoperative dissatisfaction and mandates a referral to a mental health professional before any physical treatment can even be discussed.
I love that. It takes the burden of rejection off the surgeon's personal opinion and places it on empirical data.
Precisely. It protects everyone.
What about when a patient comes in complaining of a functional issue, like claiming they feel too loose or lack physical sensation, but the surgeon suspects the root cause is actually trauma or a relationship issue?
That's where tools like the Female Sexual Function Index come into play. It's a diagnostic questionnaire that isolates different variables of sexual function desire, arousal, lubrication, pain.
So it breaks down the mechanics of the dysfunction on paper.
Right. And by doing that, the clinician can often prove whether the issue is purely anatomical or if it's deeply tied to psychosocial factors that a scalpel can never reach.
If it is psychosocial, or if they trip the wires for BDD, the protocol isn't just to show them the door and say, no thanks, is it?
No, absolutely not. The ethical mandate is to redirect them to the appropriate care. The literature is very clear that cognitive behavioral therapy, or CBT, is a highly effective treatment for conditions like BDD.
Wow, okay.
CBT helps the patient identify and dismantle the cognitive distortions that are making them so miserable about their appearance. It is the actual cure for their distress, whereas surgery is just a dangerous placebo.
We have covered an incredible amount of ground today. We started by defining the strict biological limits of what cosmetic surgery can actually achieve, contrasting real physical changes with the fantasy of psychological fixes.
You're right.
We unpacked the subtle power dynamics of coercive partners and explored the terrifying mechanism of body dysmorphic disorder, where the brain becomes so hyper-focused on a flaw that the reality of surgical danger disappears.
Which is terrifying.
Yeah, we translated the behavioral check engine lights and looked at how objective questionnaires trap extreme perfectionism on paper before it reaches the operating table.
It is a fascinating journey, really, from the mechanics of physical tissue to the deepest vulnerabilities of the human psyche. And I want to leave you with one final, incredibly sobering reality drawn from the clinical data.
Late on us.
There is substantial evidence demonstrating that undergoing cosmetic surgery can actually worsen the symptoms of body dysmorphic disorder. Think about the gravity of that for a moment.
Wait, really? So the patient finally gets the surgery they've been obsessing over. It heals perfectly, but their mental state deteriorates.
Because the surgery strips away their final coping mechanism. For years, they may have told themselves, if I just fix this one physical thing, I will finally be happy. My relationship will be saved, my trauma will be erased.
Oh, I see.
When the surgery is complete and the physical tissue is altered, but the internal emotional agony remains exactly the same, their psychological state plummets. They are forced to confront the fact that the problem was never their body to begin with.
The realization that they burn the house down, but the spider's still there.
Exactly. It leaves you pondering a profound irony about modern medicine. We live in an era of highly advanced, laser-focused, regenerative aesthetic surgery. But when a patient's pain is entirely in their mind, the most powerful and life-saving tool a highly trained surgeon possesses might not be a scalpel at all.
Right.
It might simply be the courage to look at the patient and say the word no.
Which brings us right back to our opening thought experiment. When the diagnostic waters get this murky, when the patient is offering up their physical body to solve a problem in their soul, a good clinician has to know when to put the instruments down and treat the whole human being.
Beautifully said.
Fascinating stuff, and definitely something to chew on as you go about your day. We'll catch you on the next Deep Dive.